Carey.
Thank you, my lady. The first witness this morning is Professor Bamrah. May he please be sworn?
I do solemnly, sincerely and truly declare and affirm that the evidence that I shall give shall be the truth, the whole truth, and nothing but the truth.
Professor, your full name, please.
Full name is Professor Jaswinder Singh Bamrah.
You are here to give evidence today on behalf of the Federation of Ethnic Minority Healthcare Organisations, or FEMHO for short. I hope you forgive me for calling it FEMHO. Can I make sure that you have in front of you, I hope, the two statements that you've prepared for the inquiry? The first statement dated the 22nd of December 2023, ending 399526, and the second statement dated the 28th of February 2024, ending 427706.
I do.
All right, thank you. Can I start, please, with a little bit about you? I think you are a senior consultant psychiatrist working in the NHS. And were you working in that role throughout the pandemic?
I was, yes. I mean, I was working remotely for a while, but my mother was 90 at the time, so shielding her, as well as, I suppose, myself, but but I worked throughout, yes. And I've today is the 43rd anniversary of my starting in the NHS. I was then a young, enthusiastic, somewhat excited, and very nervous doctor, and I'm that today, only less young and more nervous.
But just as excited.
Just as excited.
Well, there's an introduction. Professor, with that excitement in mind, though, can we turn to the difficult topic of the disproportionate impact of the pandemic on Black, Asian, minority ethnic healthcare workers in particular? And just to help you, and indeed those who are watching, of course, there are clearly a number of structural and wider issues at play. But today I'd really like your help, please, with the impact that the pandemic had on either creating new inequalities or exacerbating pre-existing inequalities. And just a little bit about FEMHO, though, itself. I think you say in your statement that it is a consortium comprising of 55,000 individual members, belonging to over 40 organisations and networks across the entirety of the UK. And my lady, I won't go through them, but if anyone wants to see the individual list of member organisations, they are set out in Annex 1. Could you help me, Professor, though, what type of roles does the membership cover?
So we were actually formed at the time of COVID. At the first meeting with the CMO, a number of organisations came together, and we, at that time, understood that there's a major issue in terms of Black and ethnic minority representation, as well as the issues that we were having with the morbidity and mortality statistics, which were going the wrong way. And at the time, we brought all these organizations together. They are largely doctors, nurses, pharmacists, but also people from admin background, managerial background, and from social work background.
I think it also includes cleaners, porters, catering, and other support staff. So the whole range, really, of healthcare workers that we are concentrating on. And I think you say that a number of FEMHO's members include senior medics and other healthcare professionals who act as pillars of their communities. And I'd like really to start, please, with why is it important to have representation by the ethnic minorities at a higher level and acting as a pillar of the community?
I guess all the statistics, including from NHS England, has shown that unless employees of the NHS have senior managerial positions who look like them, who are black and brown and equally represented, they are unlikely to understand those instructions, the advice, the policies, because they're not formed around them. They're not culturally sensitive.
We may look at a number of examples of that as we go through evidence this morning, but I think you say at the outset, in relation to public health communications, in many cases, they are instinctively distrusted by members of the communities. Why is there such a level of distrust?
I think much of it is in the way that these communications happen. They've happened traditionally top down rather than policies worked out with the communities, and many who've come around the Windrush generation, around from South Asian countries, they've had that feel that actually we're here as to provide a service, but not to be part of the upper echelons of the society in the NHS. And of course, over time, all the statistics have shown that there hasn't been adequate representation, even though that acknowledgement has been there, that we should be properly represented at all levels of senior management.
And translating that to the pandemic itself, how did that level of distrust or the lack of representation higher up in the NHS, how did that play out for the BAME healthcare workers on the ground?
I guess this is where it was really exposed, wasn't it? That fabric was already fragile, and during the pandemic, the issue of all these deaths amongst the black and ethnic minority people community, as well as healthcare workers, it really sent shock waves when the first 10 doctors died, all of whom were ethnic. It didn't seem as if our voice was being heard, although many of us were trying to shout from rooftops to say, look, listen, there's something going on here that shouldn't be happening. So that just festered that mistrust even more.
You said there that many of us were trying to shout from the rooftops. Does that include you, Professor?
It does, yes.
And who were you shouting to?
To everybody, the Prime Minister, the Secretary of State for Health, NHS England, pretty much wrote to everybody, starting from the end of March, really.
And in relation to NHS England, who would you be directing your shouts towards?
So initially to Sir Simon Stevens, and then to Amanda Pritchard, but also CMO and Medical Director of NHS England.
Now, you mentioned a moment ago the first 10 doctors dying being of ethnic origin. I just want to pick up on that, please. Could we have up on screen INQ 215522? And I just want to ground us in with a few statistics, but actually then ask you a bit about not the statistics, but the actual people that we are talking about. And I think you say in your statement, and I'll just preface what we're going to look at in a moment, that the NHS is the largest employer of BAME staff. 26% of its employers are BAME. It's about 340,000 people. And then by April 2020, the King's Fund article, which we've got up on screen here, referenced an analysis done that found of the 119 NHS staff known to have died in the pandemic, 64% were from an ethnic minority background, whereas in fact only 20% of NHS staff are from an ethnic minority background. This disproportionate toll is shocking. So if we think that's only 6 or so weeks into the pandemic, 6 weeks after lockdown, could we go to page 2 of that document, please? And the authors of the article say there we need to be careful about rushing to judgment before we have all of the facts, because there are higher comorbidities within people from ethnic minority backgrounds. There are ethnic minority backgrounds that constitute a disproportionately high number of key frontline workers, and those from ethnic minority groups are more likely to be concentrated in poor areas and live in overcrowded housing and intergenerational households. There's a number of reasons why there might be this disproportionate impact. But if we go a little bit further down to the paragraph beginning in short, people from ethnic minorities are more likely to have underlying health conditions that make them more vulnerable to the virus, work in roles where they're exposed to it, and live in conditions in which it is more likely to spread. As the Mayor of London, Sadiq Khan, commented, the depth of inequalities is being laid bare in a stark fashion. Now, Professor, I'm keen that this doesn't become a statistic-laden examination with you this morning, but I just wanted to set a little bit of context for the evidence that you give. And I think you are aware that following these statistics, the Chief Medical Officer commissioned Public Health England to conduct a review. And if we just look at, please, INQ 106-482, and just picking up there on some of the inequalities. The Chief Medical Officer told us, for example, that people from a BAME background were more likely to get severe COVID. Those infected were more likely to die. And you can see there, for example, in the paragraph beginning, an analysis of survival among COVID-19 cases showed that after accounting for the effect of sex, age, deprivation and region, people of Bangladeshi ethnicity had around twice the risk of death when compared to people of white British ethnicity. People of Chinese, Indian, Pakistani, other Asian, Caribbean and other black ethnicity had between 10 and 50% higher risk of death when compared to white British.
Can you remind me the date of the review?
Yes, the review came out in June of 2020.
Thank you.
Commissioned around April and published in June. So, Professor, can I ask you, against that background, when the PHE review came out, how was it received by FEMHO and its members?
So, and before that, the King's Fund, which you were referring to, had already put out the statistics. So we were, obviously, we wrote to Public Health England at the time, expressing concern and actually saying there are ways to mitigate the risks, and we'd like to be engaged and involved in discussions around this. I guess worry and alarm, particularly as many of them were very, very much on the front line and wanted to save lives, and so there was major concern around all the communities, in our organizations where all these statistics were being given. But, these statistics were important, but what was going to happen in order to mitigate against these disparities and risks, that was the major concern that people had.
And so that's exactly what I was going to ask you. Given these shocking statistics, can you help with what was done practically on the ground to try and mitigate these impacts? Some examples of things that were practically done?
I would say I would give a varying response. I don't want to say that there was no uniformity, so that was another problem. That there was some who might have acted very, very responsibly, but the feeling on the ground with frontline workers is they're not listening to us because we're not adequately equipped to look after patients. We are putting our own lives and our families' lives to risk with our work, with the way that we have to go into hospitals and support patients and treat them. So while these statistics were there, we didn't feel that enough was being done to actually give us the tools by which we could actually look after patients safely.
And what were those tools? Is that PPE?
PPE, and as we know now, pulse oximeters were not really standardized according to skin color. We also know that there was concern about respirators. There was concern that in terms of social isolation, many who lived in multi-generational households could not actually practice that safely. Some hospitals would put people up in hotels, others didn't. Some would just ask them to go home. The equipment was really, there was a lot of reprimand around masks.
Pause there, because I'm going to deal with masks as a separate topic, if I may, and we'll come back to that. I just want to stay with the levels of infection and mortality that were brought to bear. And I think in your paragraph 13 in your first witness statement, Professor, you made reference to the fact that the first 10 doctors to die were from a BAME background. And you said this, that despite the risks being obvious to many of us, there were delays around collecting, collating and analysis of data in real time. And can I just ask you about that sentence in particular? What risks were obvious to you before the PHE, before the King's Fund article? What was obvious to you and FEMHO's members?
So the first thing was, why is it that, all the first, actually then there were 14 people, all of whom were ethnic, who died. So there was an escalation in terms of numbers as well. Why is it that, black and ethnic people are dying, and why isn't NHS England or the NHS collecting data on ethnicity and race? And of course, data is key to remedy. And as it happened, data wasn't collected till late. We also wanted to know why is there any reason why these folks are dying? And our thinking at the time was really there needs to be proper risk assessment. And actually, we wrote about this at the end of March, even before the lockdown, to talk about risk assessments.
I'll come on to risk assessments as well, but in relation to the data, I think you say in your statement that one of your member organisations, the Filipino Nurses Association, began collecting data on Filipino nurses who had died and actually submitted that data to the Chief Nursing Officer because no government body was doing this.
Yes.
Who, in your opinion, should be responsible for collating the data? Is it the Department of Health, NHS England, the respective bodies across the DAs? Who do you think should be holding the pen and collecting this data?
Well, my sense is it's a governmental responsibility, and it cuts across all governments. So I think it should rest with them. Although obviously there's always delegated responsibility to Public Health England and NHS England. But I think there was that chaos, it seemed to us, that we weren't sure how policies were made, where are they made, we're not involved in these policies. But my sense about it is that this is a real, in an emergency preparedness situation, this is a government's responsibility to make sure that we are safe and that, they have data around us.
And what data would you advocate should be collected? Clearly, number of deaths is important. Number of infections, roles. What kind of data do you think actually would practically help governments and indeed those running the NHS to work out where the disproportionate impacts are being felt?
So whilst I'm not an epidemiologist, I would say that the basic data is that demographics around the person, the age, the sex, the ethnicity, the race, the occupation, where they live, because we know now that where they lived in most deprived areas were most heavily infected by the virus. So all of those data, the housing conditions, all of that data is crucially important.
And do you think FEMHO's members in the first instance would be happy to provide that data?
We would be happy to be involved in providing the data, absolutely.
I ask that because if there is a distrust of government communications and the like, it just struck me that some people might not want to engage with the provision of that data. Or is that fear, do you think, unfounded?
I think that we are professional organisations, so we would be happy while we don't have the means to collect the data. We would certainly like to be happy to be involved in the decision making in order to get the right data in the right form, culturally sensitive data there.
I think you make the point in your second statement, you don't need to turn it up, Professor, but in Wales as well, for example, there was a lack of or poor quality ethnicity data in relation to Wales. And we've heard similar evidence in relation to Northern Ireland as well, in particular, from the Chief Medical Officer from Northern Ireland. Can I ask you about a different aspect of data? Are you aware of whether there's any reliable data on the impact of long COVID on the AME healthcare workers?
No, that's another matter of concern to FEMO, that we actually don't have that data, and we know that many ethnic people were actually struck by long COVID, and the absence of that data certainly worries us. I know a number of colleagues who have long COVID but are actually providing frontline work in the NHS. They're still there, they're still beavering on, soldiering on. But that data is lacking, and that support isn't there either. It's not just about the data. Many of them tell me that they're not getting the support from organisations that they should.
Has FEMHO in any of its correspondence asked any of the government bodies to collect long COVID data?
Not specifically. We've asked generally around data to be collected, ethnicity data.
Can I ask you, please, about your paragraph 17 in your first witness statement? And you make reference there to FEMHO's members bringing to the public attention and advocating for government intervention once the data in relation to the disproportionate impact of deaths began to become publicised. And certainly we've looked briefly at PHE being asked to look at the data. I think you say there Kevin Fenton was appointed to conduct the review. And can I ask you, please, about any contact or correspondence you had with Kevin Fenton in relation to the PHE review?
So we wrote to Professor Fenton at the time, and declaration. I know Kevin very well. I was with him last week lecturing at a Black and Ethnic conference. We wrote to him saying that we thought that was a very important review that he'd carried out, and we were very pleased with the recommendations he'd made. And our concern was that the recommendations should be carried out by the government as they were set out by him. And we were concerned that that might not happen. And I don't think it did, actually.
No. I think you say in your statement that Professor Fenton invited Bamrah, one of your membership organisations, to a round table to discuss the impact of COVID-19 on minority ethnic groups. And Bamrah was asked at the meeting to follow up with representations, which they did, but they in turn did not receive any response to the representations that they made. Professor, can I ask you this? Clearly in a pandemic, not everyone can answer every piece of correspondence either as well or as promptly as one would like, but where representations from organisations like Bamrah aren't answered, does that filter down to those on the front line, and does it have any impact on them when they're feeling ignored for whatever reason?
Well, that was one of the problems. I suppose, with multi-organisations actually writing several letters, the volume, and also we've got a crisis on our hands in 2021, I understand that. But actually it shouldn't take much for the government to respond and take notice of important organisations saying, right from the front line, shouting to help them, to say we're here to help you. I think it just kind of festered that mistrust. And of course it filters down the organisation members, because we write to our members to say this is the response of whoever we wrote to, the government or Mr. Matt Hancock or whoever.
Well, in your second statement, you give an example at paragraph 8 of some ICNARC data being used to engage with the First Minister and Health Minister in Wales, which prompted better engagement, you say, in Wales, and led to the establishment of the First Minister's BAME COVID-19 advisory group. And if I understand you correctly, that sort of proactive response, or reactive response, I should say, from the Welsh Government, was that of value to Welsh BAME healthcare workers?
Yeah, I mean, the approaches, and then we're witnessing within the UK a different approach by one government, where the Welsh Government were very engaging with Professor Singhal. They actually then gave him the responsibility to develop the risk assessment tool for Wales, which we then sent to NHS England as well, which was actually informed some of the decisions eventually. But there was a lot more engagement in Wales. It was a different tone of conversation that they were having.
Can I ask, are you able to opine on why there was a different tone in Wales?
I can't say. I think it's been long held view amongst not just the black and ethnic minority people, but generally amongst the NHS employees that, I mean, NHS England sit over there. It's top down and not bottom up. And so we saw that at its worst during COVID, where they had a completely different approach to Wales, and indeed Scotland as well.
I was just going to ask you about Scotland, because I think in your paragraph 9 in statement 2, clearly in Scotland there was a similar disparity in deaths of healthcare workers amongst BAME communities. And can I ask to be called up on screen INQ 409269? Thank you very much. This is an open letter signed by more than 100 medics in early April 2020 to the Scottish Government to express concerns over PPE once the disparate effect of deaths was made clear. And I just want to ask you about some of the passages in the letter. If we could just scroll down a little bit to the paragraph starting presently. The authors of the letter say, presently what has been provided in primary care and many areas of secondary care has been thin plastic aprons, which cover very little of the wearer's body, surgical masks which have been shown only to be protective against large droplet spread, but not to smaller droplets or anything airborne, and flimsy eye cover which does not provide enough protection. Even the WHO guidelines state that a surgical gown is a minimum. But here in Scotland, we should be doing so much better for our dedicated healthcare workers who are risking their well-being daily to help combat this fatal virus. And they go on to make reference to aerosol-generating procedures. They make the point there they're worried about patients coughing and sneezing passing on the virus. And there are similar concerns about the adequacy of PPE in many areas of secondary care, and also by pharmacists who are seeing patients who attend their pharmacies. And I think, is it right, Professor, that as a result of this letter being sent, it was picked up by the media and brought to the attention of Nicola Sturgeon, who was the then First Minister, and it led to a meeting with Gregor Smith, the Scottish CMO, to highlight these issues?
Yes.
Can I ask you about Northern Ireland, though? Do you know whether there were any...
Sorry, just before we move on, do we know if anything changed as a result of the meeting with...
I think there were better dialogue between them and our organisations, and in fact then they invited again one of our chairs of the organisation there to actually give a report to the Scottish Assembly. So there's been ongoing dialogue and better relations.
Better relations, better dialogue, good, but what really good is to get the equipment that the letter was saying that people needed on the ground. Do we know whether that happened?
I think there was a general problem with the equipment, but my lady, I wouldn't want to swear on it, but I think that there was absolutely, they heard what we were saying, and there was more than an attempt to provide them with better equipment, certainly better than the flimsy gowns that they were getting. Whether that was widespread or not, I cannot say.
Thank you. Sorry to interrupt.
No, not at all. Thank you. I was going to ask you whether you knew whether any of FEMHO's membership organisations had written similar letters or tries to raise concerns with the Northern Irish ministers. Can you help with that at all, Professor? Do you know what the position was?
No, I don't think anybody wrote to, but we knew what our colleagues there were feeling.
Thank you. That letter touched on issues of access to and suitability of PPE, and I'd like to ask you about that, please. And, Professor, we've already heard a lot of evidence about PPE being either unavailable or inadequate or fit testing being failed. And I think they are consistent concerns of FEMHO's members. Is that correct? Could you just help us, please, with how does a member of FEMHO or a BAME healthcare worker take to task someone and say, this gown isn't good enough, that mask doesn't work, I didn't pass my fit test? How do they practically go about trying to get a better quality of PPE for themselves?
Oh, very hard, really, particularly.
Why?
So in March, people were already raising the question of poor supply of PPE and the inconsistent advice that trusts were giving them, and the inconsistent advice, and these are medical directors, CMOs, saying to us that they were getting inconsistent messages from right up there. And so we know of a lot of instances where medical directors would threaten the doctors and nurses, saying if they saw them with a mask in the corridor, they would be disciplined. Or if they asked for a mask, they would be disciplined. And so there was a sort of a fear that we will be disciplined. And we know that black and ethnic minority doctors and nurses certainly are more likely to be disciplined and to be sacked or erased from the register. So that fear was there, that, look, we have to keep quiet under these circumstances. But there was every attempt to raise this issue with employers as well as high up.
Well, can I ask you about that then, please? So when you talk about doctors and nurses more likely to be disciplined, is that internally by the hospital or the trust? Is that what you mean?
I mean by the regulators.
Oh, by the regulators, all right. When you heard reports, or FEMHO heard reports, that there was people being threatened with being disciplined, did you try and take any action with the regulator or with the trust to try and stop those threats being uttered?
We actually wrote to every trust, I think it would be late in April or May, I think late April, and we wrote to the Department of Health as well about this issue, that, look, we're concerned. We also wrote to the General Medical Council, I think it was just before lockdown, to say, to Charlie Massey, to say, look, we're hearing about doctors being told that if they ask for masks, they will be disciplined. And also, our doctors are saying to us that if we are not adequately equipped, we cannot work in ICU and in A&E and other frontline areas. And would we be protected by the regulator if we don't work?
I'll ask you about that last bit in a moment, but I can just stick with the threats to staff if they wore a mask when they seemingly shouldn't. Is that something that particularly affected BAME healthcare workers, or was that more generally threats? Do you know?
So you'd be looking at a biased sample from us, really. I understood that some were generic, but certainly the black and ethnic doctors and nurses and pharmacists felt more threatened by that. And there were individual examples we had of people who had been threatened.
Can you give us an example? So I could name the hospital or the trust, please.
So I can give you an example of somebody who actually, she was in her late 40s. She was a consultant in medicine. She wanted it to be open, but I don't want it to be open. She was told by the medical director that if you ask for a mask and if I see you with a mask, I will discipline you. She was working on the orthogeriatric ward. This is the orthopedic ward where you do rehabilitation for patients after a fracture of the femur, repair of the femur, that sort of thing. She actually did catch COVID from a patient, and she was very seriously unwell. She was DNR'd twice, actually. They didn't call her back. 18 months she was away from hospital. Nobody bothered to call her. She had to arrange her own test in order to see that she had COVID. From that time on, the trust completely shut shop on her.
And I hope it follows that she made a recovery.
She's got long COVID, but actually she's there. She's right on the front line. Actually, she's now a clinical director in medicine somewhere.
Now, bearing in mind that example and the evidence, I think you said in your statement that challenging authority is not the norm for some members of the Black, Asian and minority ethnic community. How do people from those communities go about then asking for better quality PPE if that's not how they have been brought up, that's not part of their cultural background? And how do we change it to make them feel enabled to challenge authority where it's appropriate?
Yeah, I mean, it's so difficult, isn't it? They do actually feel they really can't something will happen to them, like losing their job. Many of them had come from abroad for the first time just before COVID, so they were scared of doing anything that would mean the loss of a job. And I guess, they reach out to organizations like FEMO to say, look, can you provide us with support? And we've supported a large number of people over the last 4 years, including sometimes legally.
Right. I think you give an example in your second statement of, in Northern Ireland, a frontline social worker speaking to nursing colleagues. It's your paragraph 12, Professor. And those nursing colleagues were Indian, and they had anxieties they couldn't really communicate to others. Some had newly arrived in Northern Ireland and didn't want to be seen to be making a fuss by raising concerns. Can you think about how any recommendations that could be made to try and dispel that myth? It's not a fuss, it's a legitimate concern. How can we go about changing that attitude?
I think it's all, so I'm a great educator and trainer, and I think it's all about proper training, cultural awareness, cultural competence, people understanding this is the kind of culture that people who are black and minority ethnic, that's the background they come from, and if they don't complain, but they look unhappy, what is the reason behind it? So I think it's understanding that and being able to say, look, we are going to provide you with the support and not run this department with fear, which many people seem to do. You
say as well that those from minority ethnic backgrounds are less likely to be in trade unions. Why is that the position?
So many of them locum, so particularly with doctors and agency nurses, many of them are locums, and they don't belong to trade unions, most of them. So they don't have that kind of protection that some of us in substantive positions have.
Now, some of these are slightly broader issues than the impact of the pandemic itself, but can I ask you, please, about your paragraph 25 in your first witness statement and some evidence that was given in Module 1 by Sir Christopher Wormold, the Permanent Secretary to the Department of Health and Social Care. And I think you set out there that he confirmed the department had stocked lower levels of PPE suitable for black staff working in healthcare and that little planning had been done to consider the equality of PPE provisions. When FEMHO's members heard that evidence or learned of it, what was their reaction to that?
Shocked, really. Perhaps not surprised, because that was an admission of what was already prevailing at the time and had been for some time, but absolutely shocked that, there should be an admission of, well, not that there should be an admission, but that this sort of thing has been allowed to fester in our hospitals and our communities.
We've heard that PPE, in particular masks, may not suit anyone other than the white male without the beard. That's an oversimplification and it's mine, but you'll understand the general thrust of the question, Professor. Do you know if there's any work being done to procure PPE that fits a broader range of healthcare workers, in particular people with beards, for example? Do you know is anything being done about that?
So one of our members did at the time write to the Department of Health, and I can share that correspondence if I haven't already done that through our legal team. And because these were bearded Sikhs, Muslims and Jewish people, men, because they did not pass the fit test with the traditional FFP3 masks, one of them invented what was called the Tata technique, which he said passed the regulations. But then he was categorically told by HSC that they cannot agree with this, and that the requirement is to be clean shaven. Now, and we heard about this very sad instances where Sikhs and Muslim men had to shave their faces for the first time, which, you know, if you understand the religion, as I'm sure you do, this is just completely unacceptable. But they wanted to provide a service to their patients and help run the departments. So they did. Some of them did become clean-shaven for the very first time. But HSE clearly stated that this is it. You are either clean-shaven or you, and there's no attempt really to produce masks that fit bearded men, as I know.
Did you know, was any thought given to wearing the powered hoods? So you wouldn't need to shave necessarily. Do you know of any of FemHo members were offered that as a potential alternative PPE?
Not as I'm aware, and I've communicated with a lot of these folks, but not as I'm aware.
Professor, was this instruction they had to be clean-shaven written down anywhere? It's just that it seems to me such an extraordinary thing to tell people who, for religious reasons, have beards. You're confident this isn't apocryphal? I mean, do we have any hard evidence?
May I read it out to you, my lady?
So where's this coming from?
This is coming from them, the HSE.
So the HSE, so you've got something in writing?
Yes.
Yes, please.
So, based on the information provided, HSE cannot agree to the use of this method, which is the Tata method. Specifically, we make the following observations. The requirement to be clean-shaven to support an effective seal between the wearer's face and tight-fitting respirator has been in existence for many years, is not a new requirement of the current pandemic, and so on. It goes on about PPEs as well.
And Professor, can I just ask you, is that a document that's exhibited to your witness statement? I know there's a number of exhibits, and I'm afraid
I'm not sure, you know, I might...
If it's not, we will ask you for a copy of it.
Sure.
All right, thank you very much. Now, can I ask you about the AME healthcare workers who failed fit tests and what was done in the circumstances where they failed the test? Can you help with what provision was made for those who failed the tests?
So there were a lot of trusts that acted very responsibly, and you know people were responsibly as it, so there was a whole problem with PPEs, which I know has been rehearsed in this inquiry many times, and I won't go through that. So where they absolutely failed, you know, and they couldn't wear, such as bearded men, then they were shielded from work. But some, including, I know that there were about 20 or 22 Sikh dentists who then chose to get back to work. So there were people who might have gone back to work because of the, you know, the problems with resourcing departments.
So they felt they had to go back to work to help the effort.
There were people who had to go back, who felt they needed to get back to work.
Now, you did give in your second statement a more positive example of the attitude, in this case, of Wales towards PPE. Can I ask you about paragraph 15, please, in your second statement? And I think you give an example there of a nurse practitioner, an executive lead of the British Indian Nurses Association, BINA, in Wales, where that nurse practitioner considered that PPE was well organised at her hospital in Wales. And what did that nurse practitioner tell FemHo?
So she's a member of the British Indian Nurses Association, executive member of British Indian Nurses Association, and she was very pleased with how this was organised. There was a better understanding between them and the Welsh government and the Welsh hierarchy, including the CNO, and they felt that there was proper fit testing, there was proper PPE provided, but there were good risk assessments done as well. It's not in that paragraph, but that's what they felt. So they were more collaborative, so it worked out much better. There was no significant delay in the supply or availability of PPE eventually.
You spoke a moment ago about the problems with PPE for men wearing beards, but I think you also in your statement speak to the issues where many of the female Muslim members of FEMHO couldn't be fit tested to ensure PPE fit to the face because they wore a hijab. And do you know what steps, if any, were taken to fit test them or to check them if they wanted to wear their hijab as well as PPE?
So I can't tell you specifically, but I know that, I can't be specific about that.
All right. But there was reports to FEMHO, if I understand you correctly, that there was problems with fit testing.
Yes.
Female Muslims if they were wearing a hijab.
Yes, but what happened after that, I can't tell you. Be happy to find out.
And I think you also say that there were some female Muslim members in both non-clinical and non-patient facing roles who wished to cover their forearms and were threatened with referral to regulators for breaching duties when they expressed their views and their religious positions. And you say this, changes to multi-faith dress codes policy for PPE was sought by some of our members because of these problems. Do you know, in relation to the changes that you sought, whether there was any change in the...
I don't believe that there were changes.
You made the point in your statement that agency workers and locum staff were more likely to be allocated to more high-risk patients and areas. Can you give us some examples of some of the things that were being reported to you for the agency workers and locum staff?
Yes, this was commonplace throughout, actually, where they would come in and find out on the day that disproportionately they were more likely to turn up right at the coalface of COVID. And this was really pretty common practice, I would say, across for agency doctors and agency nurses. So where doctors and nurses were shielded particularly, then the agency nurses would be put in disproportionately into those jobs.
You said, for example, it could take shape in the provision of shifts to treat patients with COVID or being allocated to hot sites or COVID pathways and the like. And you say there that certainly from the Filipino Nurses Association, they described that agency nurses were being allocated to high-risk patients over non-agency staff and yet had poorer access to PPE, a double whammy, if I may put it colloquially. But is that accord with reports that you were hearing, Professor, from your members?
Indeed, and also that some of them had to purchase their own PPE. Many of them actually had to purchase their own PPE because the hospitals would not provide them.
I think you say in your statement that some of your member organisations reported that healthcare workers resorted to using bin bags instead of clinical gowns. Now, we looked at some of the correspondence with other nations in relation to PPE, but I'd like to ask you about a letter sent to the Health Secretary, Matt Hancock, in March 2020. And could we have up on screen INQ 184474? And this is a letter of the 27th of March to Mr. Hancock. It is from the British Association of Physicians of Indian Origin, BAPIO, as I think they are known. And this raises concerns about distribution of PPE and a lack of testing for frontline workers via many NHS trusts. And if we scroll down the page, we can see there an urging to him to send an urgent instruction to all NHS trusts and CCGs, PCNs, primary care networks, that PPE should be made available to all those medical nursing staff and other frontline staff who are treating patients presenting to hospital, most certainly patients with any presentation of cough or fever, regardless of underlying reason why they arrived at the hospital in the first place, and that those doctors, nurses and other staff who are deemed to be at high risk and their family members will be tested without any failures. And I think similar letters were sent to Sir Simon Stevens, the Chief Medical Officer, and I think also Stephen Powis. Do you know, as a result of those letters and letters like this, whether there was any change in the instruction as to what PPE was made available to BAME healthcare workers?
Not quickly enough, I'm afraid. So I was signatory to this letter, which I remember very well, and it was just before lockdown. Reports were already coming through. And because they were not really listening to us, then the couple of GP trainees, Viz and Joshi, who with Bindman solicitors decided to take a claim against the government. So we were signatory, we were interested party in that claim, and we decided to take the health secretary to court for poor provision or no provision of PPE.
Now, can I ask you, we've obviously looked earlier in the inquiry at some of the IPC guidance that came out, and it is generic guidance across the entire UK and doesn't suggest or allude to the fact there should be any higher quality PPE for BAME healthcare workers. I want to be clear, do FEMHO say that there should be a distinction drawn in the IPC guidance, or it should just be better PPE for everyone who's at high risk or dealing with the patients with or suspected of COVID?
Exactly that we don't expect any exclusivity, but the characteristics of having a beard are not exclusive to Muslim and Sikh people or Jewish people. You know, white men also have beards. So I think we're asking for proper fit testing and for proper equipment.
Okay. And in relation to testing, I think you set out in your statement at paragraphs 37 onwards that you learned from the members that access to testing at the beginning of the pandemic was generally poor. Again, I want to ask you, is that specific to BAME healthcare workers, or it was poor generally for everyone working in the healthcare systems?
It was poor generally, but of course we were getting reports because of the vulnerability of our folks that they felt very, exposed to the virus.
You make reference to, again, the Filipino nurses had issues accessing testing kits when they needed them. Felt they did not have priority access to testing kits, unlike other staff on more stable employment contracts. Although you make the point that the Filipino example is, I'm afraid, more widely felt across BAME healthcare workers. Is that FEMHO's position?
Yes. I think there was generally that. I mean, people were afraid to ask as well because, repeatedly, that was another thing. It's a cultural thing. So generally, they felt very isolated when it came to these policies.
Can I ask you about the second wave of the pandemic? And clearly, we've heard that it was worse for staffing levels. But you make the point that some of the members of FEMHO were excluded from clinical practice because they now were assessed as being vulnerable. I would like to ask you about perhaps the tension there, that on one hand we're protecting them more now, but therefore now excluding them from the very roles that they were trained to provide. How did that play out on the ground, Professor?
So that conflict, I was referring to that earlier, and in that conflict, of course, some people felt they had a duty to providing they were not COVID positive, provide a service even if they were exposed because of their particular vulnerabilities. I guess people took their position in that particular time. They took their position as they thought was best fit. So many of them did shield, and they wrestle with the idea that the departments. So there are some departments that are entirely run by black and ethnic people, and those departments would struggle. So it's more likely that people would feel a sense of duty to the patients and the trust and came to work. So there wasn't one formula fit at all.
You go on to say in your statement that there were a number of retired black, Asian and minority ethnic doctors and nurses that called back or volunteered to return to work. from FEMHO's perspective, was any consideration given to those cohort of workers coming back, knowing now the vulnerabilities that BAME healthcare workers have to COVID?
So we were very concerned. Of course, it was their right to want to come back and serve, because some of them obviously had recently retired and they missed providing a service to patients. But we were concerned that many of them were the very people, men mostly Asian men, and with some comorbidity, asthma or diabetes or whatever. We were actually concerned that they were properly risk assessed and then only assigned to frontline working if they were not considered to be at risk.
Presume that requires a risk assessment to be undertaken. And I'd like to ask you about that, please. You say that there were delays experienced by those that required risk assessments. Can you give us an idea about what kind of length of delay we're talking about in risk assessments being conducted?
So I think in the first instance, getting the policy off the ground was really very difficult in terms of risk assessments. I think it took off somewhere, I may be wrong, but June or July, something like that, probably a little bit later. But there were greater delays in actually implementing that policy, and trusts were implementing it variably in the trust. So some people would get risk assessments, and many were reporting to us that they're not getting risk assessed.
So either didn't get them, or when they did, they were far too late.
Yeah.
Right. Can I pick up on a statistic that you've provided, because you said there was a study conducted in June 2020 into risk assessments for Black, Asian and minority ethnic doctors, which at that time found that 65% of doctors said they had not yet had a risk assessment. And that was a survey done in June 2020. So that gives us an indication of the number of people that number of doctors, I should say, that hadn't yet had a risk assessment. Now, you say that in your second statement in Wales, in April 2020, the Chief Medical Officer in Wales and the Director General were asked to put into place an urgent stratified risk assessment, is how it's described in your statement. And the risk assessment subgroup prepared a simple risk assessment tool, which ended up becoming the All Wales COVID-19 risk assessment tool, which was launched by the government. Why, Professor, do you think it was important that there was this risk assessment tool being brought out in Wales, and what use was made of the tool?
So, the reason for that was just that Professor Singhal, who actually led on that, was able to impress on Dr. Mark Rutherford, the first secretary, that we are picking up that there are great vulnerabilities in the community, and we need to know who's exposed to the virus and who's going to be vulnerable. And I understood that actually there was a real good take-up following that. There was no resistance after that from the Welsh government to actually roll out the tool across Wales.
Yeah, I think you say in your statement that by 2021, more than 71,000 NHS and social care employees, and indeed over 74,000 public sector employees, had used an online version of the tool. Plus, there were 45,000 people using a paper version of the tool. So significant take-up in Wales.
Yes.
That, I don't know how familiar you are with that tool, Professor, but is that a tool that you would welcome being thought about being rolled out across the other nations? What's the advantage of that tool over the other tools that are available in England, Northern Ireland and Scotland? So,
well, in England, typical of us, I suppose, that there were a few of these tools eventually that were being branded around. We actually passed this tool to NHS England to say the Welsh have already implemented this, and it seems to be having a good take-up, and it seems to have all this stuff that we know about age and comorbidities and all that sort of thing, sex. And I do understand that by September 2020, the tool that came out, which I was involved with the chief executive of Wigan, I think that informed eventually the tool that he devised for NHS England.
And you said in that answer there was perhaps too many tools. Is that one from NHS England, plus one from trusts, plus tools within the hospital themselves? Can you give us an idea of how many different tools there might be?
It seemed like that, you know. It seemed that there were different ways of then trying to risk assess patients, or people rather, frontline workers.
You say in your statement that the Welsh model can be considered in comparison with the English model, where there was more of a focus on a data-intensive approach, preparing a risk assessment tool which would be linked to the patient's medical records. Is there a downside to that? Are you worried about that approach by the English model to risk assessment tools?
Well, I think what we need really, if you ask me, is, I mean, I'm a researcher, so I would say that I would be happy if somebody were to do some research on these assessment tools now. So I think the NHS should commission what is the most appropriate tool rather than wait for this to come round again.
And do you know, Professor, are these tools available in multiple languages?
No, they're not as I'm aware.
Does that pose any practical difficulties for the Black, Asian and minority ethnic healthcare workers, or is that not so much of an issue as there has to be a base understanding of English in the roles that they're performing? Yes,
for the frontline workers, all of them would speak English, so I think this would be fine, and the people who are applying the tool should be well versed in English.
And in your members' experiences, who is conducting the risk assessment? Is that being done in a culturally appropriate way, or do you have any observations to make on that?
No, they're not being conducted culturally, but that is anecdotal. You know, I know that people felt that sometimes people didn't really understand the sensitivities around the various parameters in the risk assessment tool, depending on their culture. No, the people who conducted them were the lead people. So it could be the lead clinical director or the lead manager of that particular department.
I think you say that in Scotland, you've heard from their members, there was no push from the Scottish Government to pursue an ethnicity-specific healthcare worker risk assessment tool for primary care staff. Is there a distinction to be drawn between the risk assessment tools for primary care and secondary care?
No, I think a risk assessment for a particular illness like COVID would be generic.
Okay. But at least from September 2020, the assessments did take into account ethnicity when working out the healthcare workers' risk score. Now, can I just ask you about this? Because clearly there are underlying inequalities that are well known and well rehearsed. There is clearly variation as to how much concentration a risk assessment places on ethnicity. Why, given everyone knows there's a problem with disproportionate impacts, didn't the risk assessment tools include ethnicity from the outset? Why does it take till September 2020? Do you have any observations as to why there is a delay in ethnicity being picked up in this way?
I think that's the nub of the question, isn't it? Because I think there was a general feeling that throughout, even before the pandemic, that, people, our bosses are not actually understanding that there are particular issues of culture, race and ethnicity that they need to be aware of. If they were aware of these things, which there have been multiple attempts, multiple reports, to say, look, these are very important issues to your 1.3 million employees. There has been just an abject failure to actually understand the sensitivities around that.
Can I come on then to a final larger topic, which is the guidance and communication that was issued? And I think you say that it's your paragraph 53 onwards, Professor, that the guidance was confusing, lacking in clarity, and it caused additional stress. And I'd just like to be clear, what guidance are you talking about there, Professor?
So, let me
paragraph
just get
53. It's all right.
Oh, yeah. Yeah. So, I mean, this is not just the chair of BINA saying it, but we all felt that there was complete inconsistency about what to wear, when to wear, who to wear, and all that sort of thing. And that confusion that existed caused some trust senior managers to interpret the rules according to their whim.
Can you expand on that last answer? What were they doing to interpret the rules?
Yeah, so it was like, now you can wear, you don't have to wear a mask, now you can wear a flimsy mask. And there was different grades of masks, FFP2s, FFP3s. And then there was protective clothing and aerosol generating clinics or operating theatres. There was a whole lot of confusion about this for a very long time, unnecessarily so, because there was no proper one single guidance that should have percolated right from top to all the trusts to say this is what we think in terms of health and safety. We have a health and safety regulations, but it didn't seem to us that they were applying the very rules that they were trying to try and protect.
Now, we've heard, Professor, that the UK IPC cell issued UK-wide IPC guidance, and it did obviously change as the scientific understanding about COVID changed. But just help us, from the BAME healthcare workers' perspective, why was it so difficult to have changing guidance in the way that we know had to happen in the pandemic?
Principally because it was BAME people who were either falling ill or unfortunately dying. So there was a whole lot of fear in the community, anxiety and the stress in the community. I mean, people were saying to me, I don't know whether I'm going to say goodbye to my partner today or am I saying good morning to them before I go to work? Because there was that tense, palpable anxiety amongst people. We are going to work. We do want to work. We want to save our patients. But we don't know whether our employers have our own health and safety in their mind.
Now, you make the observation in your statement that it's important, indeed vital is your words, that government guidance is accessible to everyone so that individuals can stay informed. And you say the government guidance was not culturally competent and inadequately catered to the needs of the Black, Asian and minority ethnic healthcare workers. Can you give us an example of culturally incompetent or inadequate guidance?
So I think Professor Kamlesh Kunti gave an example that in many languages, virus isn't a word. And I think that it's like that, and depression, which is an illness. I'm a psychiatrist, so I understand depression. Depression is not actually a word in an illness in many languages. So there are very many other cultures which actually don't understand the English, wordology, if you like.
Clearly, one can translate the guidance into any number of given languages, but is that a quick fix? I rather gleaned from your statement that it was more than just terminology. Are you able to help us in other ways in which the guidance was inadequate or wasn't culturally competent?
So many cultures have different customs and practices, and it's not just about the words, it's about understanding those practices that, for instance, if a woman doesn't look at you eye to eye, if you're a man, that is just the culture. It's the way that they are, it's nothing else, Yeah.
How can we translate those examples, though, into better guidance that is less confusing or is more clear? Can you think of some practical ways we can try and help to overcome those cultural differences?
I would go back to training, training of all our leaders, make sure that they understand this so that it can go down the various paths and tributaries of the NHS. Proper culture awareness, proper cultural competence, and then testing to make sure that we have updated and people have the knowledge of the various cultures we have.
Do you know, was any feedback given to the UK IPC cell about cultural incompetence or inadequacies in the way that the IPC guidance was phrased?
I don't know whether I don't remember formally writing, but I've been in many of these conferences and webinars with NHS England where we've brought up this issue.
I'd like to just look, please, at some of the steps taken by your member organisations to try and engage BAME communities with the guidance and the like. And I'm at your paragraphs 55 onwards, Professor. But I think you make the point there that there was actually quite a lot of work being done by members of the BAME community to try and spread the word, stop disinformation, engage with the communities. Can you give us some examples of things that FEMHO's members did to try and overcome some of these difficulties with the guidance?
So just simple understanding why people needed to sanitize their hands, why social distancing was important, why a vaccine uptake was important, why there were so many black and ethnic doctors and nurses and pharmacists who then became vaccinators in order to impress on people that these vaccines are quite safe to take. Well, as we knew it at the time, we felt that this was effective to try and reduce the spread and mitigate against the virus. So all of those seminars, there were many we've given you a glimpse of some of them, but there were so many of them.
Yes, I'd like to just look, please, at INQ 99685_4. And if we can just slowly scroll through, there's about 4 or 5 pages of different adverts. Some are relating to the vaccines, but as we go through a number of different webinars, lectures and the like being hosted by members of FEMHO to try and communicate with different BAME communities. And can you help us? Was this coordinated by anyone, or was this work being done off these organisations' own back, if I can put it like that?
Yes. Done very much off their own. Well, they're all valid organisations and they have structures. So, yeah, between them, they did a lot of great work.
You make the point in your statement that this voluntary effort was pursued on top of already the high workloads that these people were undertaking. You say with little to no formal support from the system. And I wanted to ask you about that, please. What support would you envisage or would be welcomed by people who are organising webinars and the like?
So these were very much weekend evenings, taken up after work. And I think there wasn't even an acknowledgement, that all of this, not that we're not looking for a pat on the back from anybody, because this is for the community and this is to improve matters in the community. I suppose, I think there should be, if this is part of your job, so there should be an acknowledgement in people's job that this is really what your duties are, and make it part of your core NHS duties, that you're an educator, a trainer, and this is what you're doing as part of that. And then with that would come the admin support that you need, because these are very senior people in the NHS who are then setting up their own seminars, setting up and flyers, from flyers up until delivery of these programs, and then getting feedback. It's quite a lot of effort, to be truthful. Some kind of admin support would have been very handy.
Melody, I just ask 1 or 2 more final questions perhaps before we take our break. And it's about this, Professor. You say in your statement that communities were often referred to, both in policy and the press, as, quote, hard to reach, implying that black, Asian and minority ethnic communities were the problem rather than the ineffectiveness of public communications. And I'd just like to ask you, do you have any suggestions for either a different phrase or a different way that people can try and communicate with communities that have hitherto been described as hard to reach?
I would say abolish the term altogether, hard to reach, because, this happens in psychiatry all the time. They're a hard to reach patient because they have schizophrenia. I see that very often. And actually, it's such a sad phrase, isn't it? It is us, how we try and... the hardness is with us, not and it sends the wrong signal because it implies that the problem is with you and not with us. And so I would say, that term really needs to be abolished altogether. So put out the title as it is, we are doing this for this reason, vaccine uptake or more information about COVID or something. Put the title up rather than putting out that we're doing this because you are so hard to reach.
I think the inquiry may be guilty of using that expression, Professor. It's all right. No, I accept any criticism. No, I'm perfectly prepared to accept a criticism if it's justified, and by the sounds of it, it may well be.
My lady, can we pause there? And there's a few more topics I need to conclude with the press after our morning break.
Certainly. I hope you're warned that we take breaks, Professor, and I shall return at 11:30.
Thank you, my lady.
All right.
Thank you, my lady. Professor, may I ask you, please, about the impact of the pandemic on the mental health of FEMHO's members? And it's at your paragraph 63 in your first statement, if you need to refer to it. But, clearly we've heard about the impact of the pandemic on the mental health, on healthcare workers generally, but can you help us with some particular examples of how it affected FEMHO's members?
How long have we got? I think this is one of the neglected areas, to be truthful, because, much as there was a lot of stress in the acute system, can you imagine our mental health workers going to A&E and A&E saying, well, actually, it's the responsibility of your trust to provide you with PPE and all the equipment, so you can't come in to see our patients because you need to be properly equipped by them, and the trust, knowing that they were keeping PPE for their staff. There was a kind of a breakdown about what the NHS is, which is that we're one organisation. So that was the stress of the work. And then patients on mental health wards having COVID, but obviously not being able to access the right medical support which they needed. And of course, we understand medicine, we are doctors, but actually we're not physicians, so treating those patients, a lot of stress, moral injury to a lot of workers during that time, not being able to give patients the kind of support, and that was generic, not being able to give patients the right amount of treatment at the right time caused a lot of pain all around. But of course, our members who articulated this to us felt really that has not been addressed even till today. Mental health as ever came right, on the back of the envelope, right at the front. So, I would have liked to have seen that to be addressed, for people to be able to articulate their fears, all the stresses that they had. There are simple things like Schwartz ward rounds that can do that.
Well, I've missed that last phrase. What kind of ward round?
Schwartz.
Help us with that, please, Professor.
So in a Schwartz ward round, somebody who's trained in that would bring people, staff together who have experienced stress, and it's proven to be very useful, where they can, in a very safe space, be able to talk about anything they want to talk about how the work and how the stresses of patients might have impacted, or care might have impacted on them.
One might say in normal times we have time for that kind of decompression and for the staff, but how practical do you think the Schwartz ward round would be at the height of the pandemic, when there are overflowing beds and more patients queuing to get into the hospitals? I'm just trying to see how practical that would be in the eye of the storm, if I can put it like that.
In the eye of the storm, not practical, you're right, but I think that but some kind of peer support is necessary, and I think a lot of people felt very lonely as they were working in A&E or in intensive care units. They felt, although there were teams around them, but actually because of, putting crudely, the death and destruction we were seeing in COVID, it was really quite for them, mentally, it was a very difficult time. And a lot of them have scars of depression, stress, which are written on them for a very long time.
Now, we've heard a little of that evidence already from a number of our witnesses to date. But just thinking about the BAME healthcare workers themselves, were there particular anxieties or stresses that were borne to bear by those communities?
Well, so because they live in multi-generational households, many of them, there was obviously that, because they were close communities that, they were bringing COVID sometimes to their family, their parents. So that was the stress of that. Many of them are migrant workers who've come here, so they have parents who live abroad in Africa or India or Pakistan, Sri Lanka, Bangladesh mostly, and they had difficulty how do we support them. So they had that issue to do with the stringent rules here where parents could not come and join them on the adult dependent rules. So I think a whole lot of cultural issues came up with them when it came to COVID.
Can we turn to recommendations that you would urge Her Ladyship to consider to try and ameliorate the impact or the disproportionate impact, or indeed some of it, on BAME healthcare workers? You touched on data collection already in your evidence, and I think you make 8 recommendations in your statement, including the need for review and investment where necessary into culturally competent and sensitive healthcare equipment. Do you include in that PPE?
Yeah, so I include in that PPE as well as pulse oximeters, as we know now, are not really designed for dark-skinned people.
Yeah. You would also urge us what you term a specific and actionable plan to address the gap in racial equality in senior management roles. And can I ask you, Professor, as laudable as that is, how practically do you think we should go about achieving that?
It's very practical, and the work and race health equality standards, which NHS England has actually constructed around the workforce, actually tells us how to do it. That's the irony of it, is that the data is there. It's not acceptable that in managerial only 15% are ethnic, and very senior management position only 11% are ethnic. Over nearly 50% of doctors are black and ethnic, and over 20% of all NHS workers are black and ethnic. So that statistics is crying out for change, and that change actually we know how to get there, because there are already it's what's behind the statistics, isn't it? That's what you're asking me, and there is a plan that is. And we would be able to help. There are organisations like FEMO, PAPIO, and other organisations are very happy to help to make this a policy.
So better engagement with organisations such as yours. We've looked at effective risk assessments, which would factor in race and ethnicity. I won't ask you about that, but if you could just stand back, Professor, and perhaps think about one central recommendation that you would like Her Ladyship to consider. Do you have one burning recommendation out of all of them?
I guess that would be that, apart from those things, is really, I think we need good training and leadership where they at the top understand the nuances of all these cultures. I think there are over 200 nationalities in the NHS from my last statistics on that. And do they have an understanding on this so that they can understand the way that black and ethnic people work? That I think there should be safer practices, safe and flexible working. There should be better protection for people who, legal and institutional protection for people who are discriminated against or bullied or harassed, if you like.
Now, I understand all of those matters, but they are potentially wider than just the impact of the pandemic. Do you have any recommendation that you would urge us to consider in the event of a future pandemic that could help FEMHO's members?
Get us into the room early. Yeah. I would say that, because I think that if we're involved right at the outset, this us and them mentality is why things were so disjointed. I would say get us into the room. It's about it's about defining policies around people, not people around policies.
My lady, those are the questions that I have. I think there are some questions.
There are, and it's Mr. Jacobs to start. Mr. Jacobs is behind you, Professor, but don't worry, he's used to people turning their back on him.
But Professor, do speak into the microphone when you give your answer. Thank you. Professor, just a few questions on behalf of the Trades Union Congress. My questions are going to focus on the position of agency, locum, bank and outsourced staff in healthcare, so really those other than indirectly employed and permanent roles. First, is it your understanding that Black, Asian and minority ethnic workers are disproportionately represented in such roles?
Are they represented in agency? Are they represented as members?
Are they disproportionately overrepresented in
disciplinary procedures? Yes.
No, just in terms of numbers of healthcare workers in those roles. So, for example, some professions in roles that are more outsourced, like cleaners and porters and what have you, do we see instances in which ethnic minorities are disproportionately overrepresented?
I haven't got an answer to that. I'm really sorry.
That's fine. I think we can move on to the next topic and look at some of what you do describe about the particular position of agency workers. In your statement and in some respects your evidence today, you've described agency workers and locum staff being more likely to be allocated to higher risk roles, agency nurses being excluded from access to PPE, agency nurses and bank nurses having greater difficulty accessing testing kits, outsourced workers in the NHS often not being given a risk assessment. Your second statement, for example, describes an account from a Northern Ireland healthcare worker who says they don't know if agency staff were risk assessed at all. When one looks at those features together, it paints a pretty grim picture, does it not, Professor, of the experiences of those healthcare workers who are not in directly employed and permanent roles.
It does.
How would you describe the particular experiences faced by those in more precarious employment roles in the pandemic, in terms of, for example, the ability to raise concerns about PPE, about the infection and prevention control they see around them and what have you?
So as you know, bank, agency, locum staff, this is a growing number in the National Health Service. And my fear is, I'm a trade unionist myself. I've been a director of the BMA. So I understand this myself, that, look, these folks don't have the kind of protection that substantive people have in employment. And that is a big worry. And because they're a growing number, I feel that they're hugely disadvantaged. That is why they've ended up in jobs that they know are frontline and that they are going to be at risk. But they can't say no. And if they said no, they would not get another job somewhere else. They don't have the kind of protection, despite our good employment laws. They don't have the kind of protection. I guess my answer is there has to be some concerted effort to bring all of them into some sort of a trade union, because I don't think currently it's working as it is. They are really very vulnerable.
That might be something that's easier for you to raise than me, Professor. One issue that Sarah Gorton has given in evidence on behalf of the Trades Union Congress is that agreements for directly employed NHS staff covering full pay for COVID sickness and self-isolation was difficult to enforce for staff who were outsourced or working via banks. Does that, to your knowledge, chime with the experience of any FEMHO members?
So that is my understanding, that, that's how it was at the time. And whether that had been a practice before that, I don't know. But certainly during the pandemic, the acute part, that's how it was.
Are these the sorts of macro-level systems and processes, as you describe in your statement, that interact with one another to generate and reinforce inequities among racial and ethnic groups?
Absolutely. Inequity and mistrust.
And if it follows from that these are the sorts of processes that need to be confronted in preparing and responding to the next pandemic, How is that to be done practically? What are the practical steps that might be taken to support the position of those in bank positions, outsourced workers and so on?
So my sense about this is really that I think it's getting, I would say that, you might say that, but I think it's about getting all the trade unions together to see how that protection might be afforded from government level to these workers. I think we've had a rule in medicine that every doctor who joins the GMC register ought to have indemnity, even if they have their own private indemnity. And I think there's a whole lot of lower paid staff workers who are particularly vulnerable because they can't afford that sort of. Why is it that they don't have it? It's because they can't afford it. If they could afford it, they would. And for low paid workers, it's even worse. And so I think there's a huge army of people there who really we could do better with getting proper representation for them.
And on some of the recommendations that you describe in your statement, so for example, in relation to risk assessments and plans for effective infection prevention and control, is it important in your view that these matters need to be tailored in various respects, but including in respect of outsourced staff? So, for example, to ensure that risk assessments are not just the preserve of employed staff, but also staff who aren't directly employed.
Absolutely. I made that point, my lady, which is that quite often they were left to their own, even, carrying these bin bags as aprons and flimsy masks. How many of these low-paid workers did we expose to the virus unnecessarily? And I think there has to be some sort of a system of support for them. After all, we're losing them because they either just go off the NHS or they become ill and can't work.
Those are my questions. Thank you very much.
Thank you very much, Mr. Jacobs. Ms. McDermott. That way, Professor. Ms. McDermott's within your eye line.
Good morning, Professor. Professor Bamrah, today I will be asking questions on behalf of the UK COVID Bereaved Families for Justice and the Northern Ireland COVID Bereaved Family for Justice. And firstly, congratulations on your 43 years in the NHS. It's a remarkable feat. My first question is about what you started with in your evidence, and it was a common theme throughout your evidence about how it didn't seem as though the Black and Asian and minority ethnic voices of the healthcare workers were being heard. And you've given some striking examples this morning and in both your statements of evidence of the impact and consequences brought about by not hearing those voices. So plainly from your evidence, many within the BAME community were afraid to speak out. My question is this, specifically at paragraph 42 of your first statement, you recount how many healthcare workers express fear of speaking out about unfair redeployment due to concerns over negative repercussions. I don't know if you want to have an opportunity to reflect on that paragraph. But my question is this. In your view, was this fear justified? And what specific consequences do you think those particular employees risked by speaking out?
Yes, sorry, but they were justified. I'm sure you understand that because that was the practicality on the shop floor that many of them were very, very fearful of actually going against. It's also a cultural thing that if you're a senior person or you're older than the person, that you don't challenge them as well. That's also a kind of a cultural thing. So there was a lot of anxiety and stress about this. There was a lot of fear that they dare not tell them that the rules are being broken and they are being impartial in some ways or even racist in some ways. That word that is often just in the background but not used in the NHS. So I think, yes, I think that it was justified. What was your other question?
The second question is about the consequences and what were the specific consequences do you think those particular employees feared should they have spoken out?
So the worst consequence, isn't it, that they would lose their job? And as I was referring to, certainly when you look at the statistics in terms of the disciplinary action taken against doctors and nurses, you will find that they're disproportionately from the black and ethnic minority community. So that's the ultimate consequence. There are other, what I call microaggressions, I don't know whether you like that term or not, which is, ignoring somebody, not including them in communications, not talking to them, not encouraging them, not planning their PDP or supporting them with CPD. There are so many different ways that these malcommunications happen, which undermine that person and undermine their morale, who's, after all, a person who just wants to do their best in that job. I think everybody wants to do the best in their job unless proven otherwise.
I'm grateful for that fulsome answer. Can I take you then, you mentioned statistics, and I'm going to bring you to a Northern Ireland focus, because I know Ms Carey Casey's questions have been navigated this morning so as not to be statistic-laden, but statistics on the numbers of BAME care workers in Northern Ireland are very difficult to unearth. If you just bear with me one moment when I explain this, an example of that is that the data from the 2021 census for Northern Ireland indicated that almost 12,000 of the 60,000 workers within the healthcare sector were not born in Northern Ireland. And more specifically, Belfast Trust had around 47.1% of graduate nurses employed between April 21 and March 23 were from abroad. But the census does not reveal the ethnicity. Now, in Module 3, the Northern Ireland Chief Medical Officer, Professor Sir Michael McBride, had spoken about data in relation to age, in relation to gender and social deprivation, and being able to use and analyse that data. But within that same paragraph of his statement, and that's for the record, paragraph 424, he cites, analysis regarding ethnic minorities was not available due to the poor coding of ethnicity in healthcare records, and it was not possible to look at trends in those from different ethnic backgrounds, nor to analyse differential impacts of the pandemic according to ethnicity in our general population. My question is about the chasm of information, and reflecting on your evidence today and reflecting on the point that you've made about the need for the NHS to commission a risk assessment tool. Do you agree, perhaps more generally and more urgently, that the gap in data for Northern Ireland should be urgently addressed?
The answer is absolutely yes. I mean, I'm concerned that, it's okay to give these statistics, Sir Michael, but actually then say what your next step is going to be to address this huge, unless you have the data. As I said, I'm a researcher. Unless you have the data, unless you know what's happening, you can't actually address it. And I can't see. I mean, you've given some data there. I mean, it might be these are kind of crude data, but they tell you a story that actually we need to look at all of these people who are coming there. And it's about retention and recruitment as well, isn't it? If everybody feels valued, then they will give the best in the job that they can. And if they're just a statistic or even a non-statistic, then how are they going to do their best for the NHS?
And I think moving on from that, but within the same rubric, the information and what you do with that data and how it informs policies right up to the top. And we've heard some evidence today regarding the engagement between FEMO and devolved nation governments. But specifically at paragraphs 5 to 8 of your second statement, you talk about the increased awareness and concerns in Wales and Scotland regarding COVID infection rates and the disproportionately high mortality rates for BAME healthcare workers. And to this end, you even managed to set out some of your responses from the First Minister levels from Scotland and Wales. And it will be for the inquiry to consider the adequacy of those responses. But are you aware of the Northern Ireland government response in relation to the high BAME mortality rates?
I'm not actually, unfortunately, and I think it's probably a gap in my system that I should have been addressing. We did address the issue of the workers there, but in terms of our engagement with the First Minister there was a gap.
But is that a gap also informed from the information chasm that we've mentioned?
Yes, I mean, I think it's evident that, I mean, it works both ways, doesn't it? That there should have been some attempt on them to engage with communities there, which I don't think there was from the government. So if there was, I don't know about it, to be truthful, because I guess they would have contacted somebody like myself.
I'm very grateful for your answers and responding to my questions, Professor. Those are my questions.
Thank you very much. I'm very grateful. That completes the evidence for you, Professor. You've been a very eloquent witness and obviously a very eloquent spokesperson too for a large number of communities, I suspect. Thank you very much for the constructive nature of your evidence. And I too would like to wish you, again, a happy anniversary.
Thank you.
Stay in the NHS as long as you can.
Thank you.
Thank you, my lady.
Thank you.
There may just be a brief pause now while we...
I'll stay here. But
thank you very much.
Yeah.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Dr. Finnis, I hope we haven't kept you waiting for too long.
No, not at all.
Dr. Finnis, your full name, please.
Catherine Finnis.
All right. You made a witness statement on behalf of the Clinically Vulnerable's Family Core Participant Group, dated the 31st of January 2024, our INQ 409574, and I hope you have a copy of that in front of you.
I do, yes.
All right, thank you. A little bit of background to both you and indeed to CVF as they are known. I think that you trained as a medical doctor some years ago now and practiced for 5 years when you needed to leave face-to-face clinical work due to you being severely immune suppressed. Is that correct?
That's correct.
And is that why, in part, you appear with a face mask today?
Yes, that's correct.
Right. You've got a nice loud voice. Please keep it that way. Nice and slow as well, please, doctor, so that the stenographer can keep up. All right. I think having left face-to-face clinical work, you completed a master's degree in health services research, and you now work in a non-patient facing role within the NHS.
That's correct.
Right. And you are the volunteer deputy leader of CVF.
That's correct.
Right. And can you just help us, please, with a little bit about CVF? I think you say they were formed in August of 2020. And what was the reason for the formation of CVF?
Yes, that's right. So CVF was formed in August 2020 at a time when shielding had been paused and children were required to be back in school in September 2020. What that meant was that for people who were living within clinically vulnerable families, they were concerned about the risk of their children returning to school and indeed contracting COVID. This is despite the assurances at the time that schools were safe and that children indeed didn't transmit COVID. But Clinically Vulnerable Families was set up by Lara Wong, who was a teacher, and she recognised the risks to parents of children returning to school and indeed clinically vulnerable and clinically extremely vulnerable teachers who were also required to return to school in September 2020.
So pausing there, we understand that the genesis of CVF was because of the concerns about going back to school. Now, you'll appreciate, Dr. Finnis, that we're concentrating on the impact of the pandemic within the healthcare systems. And so that's not to minimise the impact on children, and indeed the teachers who were clinically vulnerable or clinically extremely vulnerable. But can we focus today on healthcare systems impact, if we may? And I think you say this, that there's a combined membership of and following of CVF at just under 46,000 people. And there are a number of members on Facebook, followers on Twitter and the like. And that CVF's mission is to support, inform and advocate for those in clinically vulnerable households as they face an ongoing threat posed by COVID-19. Right. Can I ask you, please, Doctor, I might concentrate firstly on clinically extremely vulnerable and then on clinically vulnerable. Some different issues may arise, but clearly if I talk about one and there's an issue for the other group, please do say so. Mm-hmm. And can I at the outset thank you very much for the helpful quotations that are peppered throughout the statement. We may look at one or two, but if we don't have time this morning and during the course of evidence, there is a litany of quotations from the people themselves who were affected. And I think it's right, as a result of your medical problems, were you on the shielded patients list?
Yes, that's correct.
Okay, so if you have your own experience to bring to bear, as well as speaking on behalf of CVF, please do say so. Right. Can I start, please, with clinically extremely vulnerable people and the shielding list? And indeed, we have heard about the makeup of the CEV list from Professor Whitty and others who gave evidence to us earlier, but it might just be easier to call up on screen, please, INQ 409-574_10, just to remind ourselves, without having to go through it, those that, as at the 1st of April, were deemed to be at the highest clinical risk, and a number of different people with medical vulnerabilities set out there. And I think, is it right that CVF have concerns about who was on it who should not have been, and conversely, who was not on it who should have been? So can I ask you about those two sides of the coin, please?
Yeah, that's absolutely right. So as we understand it, there was an algorithm initially who identified people who should be put on the shielding list. But there were people, because algorithms are never perfect and there's a data quality issue that I think you've heard about within the NHS anyway, some people weren't identified by the algorithm. They were then left thinking, well, I don't appear to have been told that I'm being shielded. And that then led them to contact their general practitioner to ask whether they indeed could be added on. However, that did bring about delays to shielding. And as we'll go on to talk about, probably the benefits of shielding was that you actually had a passport through that shielding letter to enable you to work from home.
Yeah.
So people who were delayed not being able to do that, and who, for example, had frontline jobs, as you've just heard the previous witness say, were required to still go into frontline jobs until they had those letters.
Now, although there are, I think, the different medical categories, we were also told that if a GP identified a patient as being clinically extremely vulnerable, they could be added to the list, and indeed people could ask themselves to be added to it. And you said that led to delays. Are you able to help us from CVF's perspective how long it took if you were in that latter category of asking your GP to be added?
Well,
days, weeks, months?
Yes, it could take weeks. And that was because the GPs themselves, everything had changed at that time. So it was quite hard actually to sometimes contact your GP. Everything was remote. People didn't know really who to contact. Everyone was very worried, scared at that time. They knew that they had a vulnerability. The list was publicly available and they thought they should be on it. And so it was a very worrying time for them. They knew they should be on the list. They didn't have a shielding letter. They weren't able to work from home at that time. So their life was potentially at risk. And indeed, being put on the shielding list could then take weeks.
From CVF's perspective, is there a category or type of condition on here that you think should not be on the shielding list?
No.
No. All right. Now, what about the timing of the compilation of the list? I think you say in your statement that obviously we went into lockdown on the 23rd of March, and the letters started to be sent to people, I think, a couple of days earlier on the 21st of March. Clearly, that was some time since reports in early January or thereabouts of the emergence of the coronavirus in Wuhan. Does CBF have any concerns about the timing of the compilation of the list?
Yeah, very much so. So obviously we were aware, or those of us that were aware, of which many people that had underlying conditions were watching closely the pandemic, because we soon realised that people, sadly, who were dying had underlying conditions. And so we had worked out really that we were at higher risk, and we were obviously watching initially the WHO and the problems in China, and then later, of course, the terrible problems in Italy, and indeed that was being beamed into our front rooms on television, and then people with these underlying conditions, and even telling us what they were, even at that point. It was very late. The shielding timetable, when people were told to shield, seemed very late into March. And indeed, when you look at the timing of the first wave, I think CVF would suggest it was too late, and that in fact some of those clinically extremely vulnerable people could have been told to shield earlier and not have become infected.
Well, I think you say in your statement that actually there was effectively an informal shielding that commenced earlier by some of CVF's members. Are you able to give us an idea of how many of your members started shielding before the letters were actually sent out?
Yeah, I don't have a number for you, but certainly when I wrote to our group to do some thematic analysis to understand this, it certainly was a dominant theme that came. So it was a large number of people who were able to do that. However, there is kind of discrepancies or inequalities, if you like, about who was able to shield informally. So people of working age, particularly people in frontline roles such as teachers, nurses, doctors, shop workers, bus drivers, taxi drivers, were unable to shield informally because they could not work from home. Okay. People like myself who had office work, I was able to discuss it with my boss, and I was given allowance to work from home, as were some of us in those roles. But certainly it was very late.
So there are those whose perhaps work allowed it could start informal shielding, but without the letter to say you should be staying at home and should not go to work, it made it very difficult for those clinically extremely vulnerable people to start any informal or pre-shielding. Is that?
Absolutely, and we've got quite a few teachers actually within our group due to how it was actually set up. And for teachers, it was really difficult. They were in school every day with lots of children. They knew that they had one of these conditions on the list, and they were not told to shield. They were not actually given any information what to do. There was no real education. I think at the time we were being told to wash our hands to happy birthday, as I recall. And that was really all the advice. So it was a really stressful time. I guess the group of people for whom we represent that were able to shield informally the most were older people who were retired.
Yeah. Well, can I ask you about that? Because can we have a look on screen, please, at INQ 474233_190? And I think, Dr. Finnis, you have read the shielding chapter of the Every Story Matters record. And indeed, on the first page of the shielding section, there is reference there to a number of clinically vulnerable and clinically extremely vulnerable telling ESM about how frightened they were at the start of the pandemic. And we can see there in the second sentence down, early in the pandemic, some avoided all contact with people outside of their immediate family because they were anxious about catching the virus. Some did this before there was any official advice, aware of the risk associated with their health conditions. And you can see a quotation there. You didn't know what way it was going to go or how bad it was going to be, especially in the early part. Everywhere was closing down. It was very, very scary. And does that echo members of CVF and the concerns that they were enunciating?
Yeah, that was absolutely the case. I think also, I know it does say here early in the pandemic, some avoided all contact with people outside of their immediate family. But of course, for many members of our group, that continued throughout the emergency part of the pandemic, and for some people it even continues largely today. Yeah.
Understood. Can I ask you about the communications that went out to CVF's members? We know there was a letter sent by GPs, but I'd like to ask you, please, about a text message that I think one of the CVF members, and could we have a look on screen at INQ 408799? And I think this is provided by one of your members as a text that they received, I think before they'd got the letter. Is that correct?
Yes, I believe that is the case. And actually quite a lot of us did receive digital communications, either by text and or email, before we received the letters. In fact, personally, I think I received my letter maybe 2 weeks later, but I received a text very quickly.
All right, and then look at the text. I think it was sent on the 24th of March, received at 9:46 from the NHS Coronavirus Service. Do you know how you will get your medicines while you're staying in your home? You can order repeat prescriptions online. It gives the website address. Please ask your family, friends or neighbours to pick up your prescriptions from a pharmacy. Just remind them to leave the items outside your door. The NHS is still here for you. You will still get the care you need, but the way you receive it might change. More will happen over the phone and internet. Do you know how CVF members reacted if they got the text before they had the shielding letter, and how it impacted them to receive a text like this?
There were lots of different texts being received. There was one that said, you can open your window, but do not go outside of your home. Put a medical bag ready to be taken to hospital by the front door. I mean, these were very frightening messages to a group of people who hadn't really been given any information on how to reduce their risk. For example, we were simply told to stay at home. Many people within clinically vulnerable families didn't see themselves as vulnerable, as indeed I didn't. I was a part of, or am a part of, the society, community. I have a job, I have a child. You know, a lot of us were in those situations, and then suddenly we were disempowered hugely by really being told to just stay at home. This particular text was really, worrying, because again, highly disempowering, asking your family, friends, or neighbours to pick up your prescriptions from a pharmacy. But they're not necessarily people who are used to asking people to do things for them. They were often stalwarts of the community who were doing things for other older people. Many of us have older parents, for example. We wouldn't want to put them in harm's way. And indeed, we weren't necessarily part of those kind of, maybe I would say, older age community groups to support us. So a lot of us were very perplexed by these texts. We didn't really know what to do. We felt really stuck. Many people, we didn't know how to get our prescriptions. And these texts, they make it seem quite sort of easy. You know, you can order repeat prescriptions online on the NHS app. Lots of people didn't have the NHS app at that point. Lots of us weren't plugged into remote pharmacy deliveries at that time, because obviously before we could go to the pharmacy and collect our medications on the way home from work, for example. But suddenly we're being told we can't do all of these normal things, and we must now ask other people. And that was really problematic for our group. I just want to talk about the clinically vulnerable if I can here, because I think it's really important, because although they were never formally shielded, they were obviously told they were at higher risk. And they too often needed medication, for example, diabetics, asthmatics, needed really life-saving, important medication. They also were sort of advised to obviously ask family and friends, etc. But there was a real problem that developed with the clinically vulnerable, as I understand it from members in our group, who said that, well, you're only clinically vulnerable. You're not clinically extremely vulnerable. You're not shielded. And people started to not want to put themselves in harm's way to help those people.
Dr. Finnis, can I just stay with that text for one moment? Do you, on behalf of your members, think there should be no text at all in these circumstances, or is it there's an issue with the timing with which they came out, and then indeed an issue with the content and the way it was delivered? I just want to be clear about what your sort of position is and how we might do something differently in the future?
I think it was a good idea to use all communication, to be honest. I mean, we would say that the timing was too late. It was already lockdown, wasn't it, by now? So we should have received these before that. I think the information is difficult. I think, they do need to give people information. I guess it's all just about planning for me. Why had they not set some of this stuff up already? Why did we not know that we could order prescriptions from the pharmacy, for example, in February or late February or early March? Why leave it until we got to lockdown? The other thing I just want to say about these texts, I received tens of texts, tens of letters, loads of emails. It was really frightening, and constantly to be told that you're at high risk of dying should you step outside your house for a period of amounted to, from March 2020 to summer 2021. It's really difficult for people to cope with.
Could you speak a little more slowly?
Sorry.
It's probably my fault, Doctor. And I just was listening to that answer there. It strikes me that the balance between providing the right amount of information at the right time is what's the issue here. No one's going to complain about being told what to do if you're being asked to shield, but to be bombarded with it is perhaps not helpful either. Mm-hmm. I understand. Can I ask you this, though, in particular? There are core participants here on behalf of the Welsh bereaved group who make reference to a processing error in the Welsh Government's communications in April 2020, which resulted in 13,000 shielding letters being sent to the wrong address and arriving 2 weeks late. Did CVF's members experience this? And if so, what was the impact on them of receiving the letters so late?
So just to clarify, these were people who should have been shielded, so just late letters. So we have members throughout the group who were told or given information about to shield over the whole period, over the whole 18-month period of shielding. Initially, there was all sorts of problems. There were people for whom they certainly didn't get their letters straight away. It was a bit of a problem, as I recall, in terms of using it as a passport to be able to work from home. If you didn't have the written letter, it felt as though the written letter was still the formal communication rather than a text message.
Well, you've touched on there some of the measures that were designed to assist those who were on the shielding patients list, including entitlement to statutory sick pay, which would have helped in those examples where people could no longer go to work. I think you also say that in the information that was sent out, there was early emphasis on hand washing. Mm-hmm. Is that correct?
Yes.
And there was no information on the airborne or droplet spread of COVID-19. Now, put aside the controversies about the amount of transmission and how it was transmitted, why would it made a difference if there'd been information about the route of transmission?
It would empower people. So people would be able to, with advice and guidance, try and prevent their risk, their real risk, and also understand what the risk really was. Because without really being told or just wash your hands, COVID obviously is an invisible risk, but not telling people the route of transmission, just telling people to stay at home, it was being made a prisoner in your own home without any real understanding why and how you might, why can we not go outside our house? And shielded people lived in different places. So some people lived in the middle of the countryside. Why could they not go for a walk outside their house or indeed their garden? We were initially told not to go into our gardens.
Can I ask you this? You may have heard some of the evidence that suggests there was uncertainty about the route of transmission. Do you think it would have helped CVF people if the communications had said, we don't know yet what the route of transmission is? Would that have been important to CVF's members?
Yeah, absolutely. I think any information that you can give people, though we were scared and frightened, we were, there's many capable people in society, as we know, and many capable people who have underlying conditions, and they would be really ready to understand that information, to empower themselves to be able to reduce their own risk. And indeed, that's what CVF has tried to do. That's what we've been doing, is really filling that gap from August 2020, trying to inform people about what masks can be worn, whether it's droplet or airborne, to be honest. What other things you can do to reduce your spread, ventilation, being outside, things like that.
Yeah, we'll come on to ventilation, I think, as a separate topic. And I ask you about masking, though. I think you said in your statement that in the information that was given to shielded people, there was no advice on masking. Do you mean it didn't mention masks at all?
No, I don't believe that, certainly in the shielding letters, texts, or emails I received, that anything was ever said about face masks. There may have been something said about face covering a bit later on, but certainly not in that initial wave. I don't believe there was anything at all about face masks or face coverings.
Do you think there should have been?
Yes.
Did CVF provide any advice or support when its members started to query? I appreciate it was slightly later into the pandemic once CVF was set up, but were you receiving queries about what type of mask to wear in what circumstances?
Absolutely, yes. And we are still receiving those queries to today. So one of our missions, if you like, is to really try and educate people and offer that sort of gap that remains even now in education between the type of masks I know you've been through, which ones to wear when, and indeed which ones to wear when accessing different kinds of medical treatment. So, for example, one that I'm wearing at the moment that has metal over it, you can't wear in an MRI machine, but there are masks available that you can wear, and so we let our members know which is the best mask for them.
And you, is it by choice that you've chosen to wear the mask that you are?
Yes.
Is there any reason why you didn't choose to wear the blue FRSM masks?
So I'm wearing an FFP3, so I know that this is much higher filtering capability, in excess of 99%. Although I am severely immunosuppressed, I do still live a limited life like a lot of us do. Despite that, I do actually do most things wearing an FFP3, and I'm yet to catch COVID.
One of the other offers of support, if that be the right phrase, was there was a suggestion that there would be, in January 2021, those in residential or nursing homes would be offered a free supply of vitamin D through the post if they were clinically extremely vulnerable. Was that ever expanded to those that weren't living in or residing in the care sector?
Yes, so I believe it was offered to everybody who was on the shielding list. So I certainly was offered a supply of vitamin D. I think what perplexed me at the time and still now is why at that point I received my stash of vitamin D through the post. Why not just give an FFP2 or 3 mask in the post? Why not use that opportunity to send those more protective masks to those very vulnerable people at that time?
Were you offered any PPE at all?
No.
What about lateral flow tests and the like? Were you offered those when they became available?
Yes. So we were able to access lateral flow tests. Initially, we were able to order online as many boxes as we needed. But then there's been a reducing access. So then it was only the clinically extremely vulnerable, or actually it was the person who could access antivirals, which is a different list. It became really complicated. That was one of the other issues. But if you could access antivirals, then which wasn't necessarily the shielded list, but a lot of them, but involved some clinically vulnerable, for example, then you could order your box of lateral flow tests that would come for you. And now we cannot order them at all, and we all do have to go into a pharmacy to get them, which is not easy. There's no real process, and it's risky.
can I ask you about some of the impacts of shielding on the clinically extremely vulnerable? And you say, Doctor, at your paragraph 44, that shielding, despite all its challenges, and we'll look at some of the challenges in a moment, that it was often a reassurance and a practical help to clinically extremely vulnerable. Help us, please, with how it reassured people and perhaps some more positive aspects to the shielding programme before we look at perhaps some of the negative aspects.
I think given how worried people were with the information coming from first China and then Italy, and understanding that people with underlying conditions were at much higher risk of severe disease and sadly death, I think that shielding was something for us to at least hold on to. It felt that perhaps we were being offered something by society. I think that it was really important, that whole passporting aspect of it, that you could work from home, or indeed if you could not work from home, that you were then offered statutory sick pay, which meant that you could at least afford to shield. So from that perspective, I think it was helpful. There was other things such as food parcels. We were sent food parcels early on, just in the first wave. There was also something about supermarket shopping. So we were given free slots, essentially, to enable. But that took a while to kick in, to be honest. There was a first few hairy weeks where if we weren't prepared, and maybe that was one of the problems, was that because we weren't really forewarned, all of a sudden we were perhaps stuck at home without any food in the larder, and we were in lockdown.
Yeah.
You know,
Comes back to preparedness,
as
so many answers often do, if I may offer that comment. Can I ask you, though, about some of the more negative impacts of shielding? And I think in particular it might be helpful to look on screen at INQ 408810, and some research that was conducted by the Health Foundation. And if we just look at the second paragraph there, the analysis conducted by the Health Foundation shows that CEV people experienced a higher rate of deaths compared to the general population over the pandemic. At the peak of the first wave on the 2nd of April 2020, the rate of deaths amongst the clinically vulnerable population was over 2.5 times that in the general population. 1 in 2,500 compared to 1 in 7,000. Furthermore, by the end of August, the clinically extremely vulnerable population accounted for 19% of all deaths, while only making up 4% of the total population. And so clearly there is statistically a higher risk of death for those who were deemed to be CEV. I think there was also a decrease in CEV people attending planned admissions and emergency admissions, and that is set out in the third paragraph there. And clearly there may be all sorts of other emotional, psychological, mental ill health side effects to those who were asked to shield. As a shielder yourself, may I ask, do you think the upsides outweigh the downsides, or vice versa?
Yes, I think they do. And I think they did. I think that the problem was, it's difficult, isn't it? In talking about the past, I think that's true, because we were left with nothing else at that point. It was kind of dire straits, as you've heard, and that actually to get the information out really quickly to people who, as shown here, were at very much higher risk of death, to get them as safe as could be anyway at that time, I think that it was of benefit, but I'm not sure that's true for a future pandemic. I would hope that there would be, obviously, hopefully from this inquiry, but that, you know, suggestions for better planning and things could be arranged in a better way and a more empowering way for people who are at greater risk, rather than just leaving this only option of locking them away.
You say in your statement that the negative effects of shielding were at least in part because of the poor quality of the guidance rather than necessarily the need to shield itself. And I wonder if it might be easier to look on screen, please, at your paragraph 57. It's INQ 409574 underscored 25 into page 26, which just sets out and encapsulates the concerns about the guidance. And it's that, they are paragraph 57. Our view is that the negative effects were at least in part because of the poor quality of the guidance, rather than necessarily the need to shield. The content of the guidance was sometimes scary and constantly changed. The advice was often unachievable and certainly was insufficiently reassuring. Additionally, and then you set out there a number of different aspects to the guidance. It failed to ensure complete household protection, focusing on the CEV individual, but often neglecting the risk posed by non-shielded house members. Just thinking about that aspect of the guidance, Dr. Finnis, what do you think the guidance should say next time if we have to have a shielding programme?
I believe that you should shield the household, everybody that lives within the house, because one of the problems with the shielding guideline is that it told us to stay 2 metres away from everybody within our household at all times, including our children. And this was really challenging. Of course, though, if we didn't, then those other people potentially was a threat to life. So we were left in a very difficult situation within our own houses. And in fact, that we have members who, I mean, it drove people to extreme situations. So, for example, caravan, staying outside on their own in a caravan in their front garden, moving into their shed in the back garden or into the loft. And we also have people who live their life completely upside down. So their family were up in the day and then they did their cooking and eating in the night.
I suppose, to play devil's advocate, there might be other members of the household, though, that don't want to take those steps, no matter how protective it is of the CEV individual. Do you think there needs to be a better balance struck in the guidance that is offered to the non-shielded person in the household?
I think it's essentially guidance. So I think that the whole point really is that the whole family should have the protection to work from home or to get SSP, or the child to be home educated, remote educated, rather than put that risk, because it's not only that those people, I mean, generally speaking in families, people want to protect their mum or dad or brother or sister. And in fact, it was psychologically extremely difficult for people to still go out and do those jobs, knowing that they may well return home with a virus that could kill their loved one. So, in fact, the pressure on those families during that time was immense. So I think it is guidance, but I think that you should at least have that as a protection, that everybody can use those passporting to protect the shielded person if it's right for them.
Can I ask you about just a couple more of the sub-paragraphs in your paragraph 57? You say that the guidance contributed to significant mental health challenges due to isolation, an impact that could have been mitigated with more thoughtful guidance. And can you help us practically, if you're able to, in what way could it have been more thoughtful?
It was very, like we've already said, it was very focused. I mean, I personally found it very triggering, to want to use the modern parlance, constantly, every day, every week, every month, for months and months on end, I was told that if I go outside my house, I might die. And, having some kind of support or some kind of, even just basic kind of how to relax kind of tips, or some kind of maybe online how to relax, or some more information about, because it was just so stressful, how to reduce the impact of that. And some community hubs did this, but certainly I don't remember any of the shielding guidance, but just letting people know what was available online for them to join. So, for example, book clubs were set up, or there was even a choir that you could do remotely from your home. And so just telling people of those things rather than just leaving it up to the person to go searching.
Did CVF, once it was established, provide advice or provide any kind of information to its members as to how they could access something to try and at least release some of the burden?
So we had a weekly mental health post on our Facebook page where people could add a different coloured heart, and then depending on the colour heart meant the sort of support that we then went in and offered. We also have CVF coffee evenings, and those are regular, even today, where people who are still very vulnerable and high risk today can at least have some social life.
That can be taken off the screen. Can I ask you, please, though, about CVF members' experience when they had to attend healthcare settings? And I think in particular, we've already heard some evidence about use of masks in hospital, and indeed CVF members attending hospital wearing masks and being asked to remove them. So can you help us, Dr. Finnis, with how CVF have found it when they've had to go to appointments in hospitals, GPs and the like?
Yeah, so it's changed throughout the pandemic. So initially, obviously, it was mainly remote, and generally speaking, our membership actually seems to like remote, generally, although we also recognise it's not right for everyone and there should be a choice. And that, of course, it shouldn't be a choice of remote because healthcare isn't safe. That's what we would say, that it should be a real choice. Other things that happened was that some of our members went to hospitals and were wearing a mask like I'm wearing today, a good quality mask, well fitted, and they were asked to remove it and put on the blue FRSM mask that we knew and clinically vulnerable family members knew was not as protective. That was very stressful, very worrying for them. I actually experienced it myself, and I spent quite a long time outside just with the reception staff, kind of advocating for myself that I needed to wear this mask, but it felt that I was better educated than the healthcare staff at that point. And ultimately, there was no real fix to it. I was asked to remove it.
Well, that's why I was going to, who won, I suppose, is an elegant way of putting it. Do you think, how did the staff react, though, when they saw you coming in wearing a mask and saying, look, I need to wear it because I have these underlying health conditions?
Yeah, I mean,
they seem to know how they were supposed to deal with it.
Yeah, so certainly during the main part of the emergency part of the pandemic, I think because more people were wearing masks, it was more accepted. But there has been a real kind of sea change, I would say, really from when face masks were removed from hospitals in summer of 2022 in England. And in fact, we've done some polls in CVF, which shows the problem. So just before the masks were removed, we did a poll in 2022, and it was with hundreds of people who were clinically vulnerable. And they were asked whether they had delayed or cancelled any appointments, and we were told that I think it was about just above 50% had done that. Move on to November, though, of that year, in 2022, and we asked the question again, the same question, to the same group, and they over 90% now were telling us that they were delaying or cancelling appointments or operations in hospital. And we repeated it again actually in November 23. We need to repeat it again this year. And again, it's over 90% delayed or cancelled appointments and operations. Now, this is because people are now really worried. There are no mitigations in hospitals. And moreover, people who go in wearing a mask, and we've had many, many reports now of people being sort of gaslit why they need to wear one, belittled, made fun of, harassed, dismissed. That's despite the if I may, the government guidance still. So if you go on gov.uk and you look for COVID-19 guidance today for people who are severely immunosuppressed or higher risk, it tells us several things, if I may.
Well, can I just pause you, because you've given a lot of information there that I want to pick up on. And don't worry, Doctor, we will cover it. But I just wanted to ask you this. In your poll, in June 2022, if I understand it correctly, 54% of the contributors to the survey said they delayed or cancelled healthcare appointments.
Yes.
It jumps in October of that year, if I understand it, to 91%. Now, do you know why there was the jump between June and October?
Yes, because it was a drop-in of face masks from hospitals.
Right. And have your members told you that, or is that something
Yes.
that you surmise from
Yes.
the timings?
Yes, I mean, our pages now, even today, are full of people having trouble accessing hospitals. They are unsafe for people who are clinically vulnerable. And one of the problems why they're unsafe is because of the problems of face masks. Staff aren't wearing them, but neither are patients.
Pause there, please, Doctor, because there's a quote in your statement that I'd like to just put up on screen. It's
And
INQ.
more slowly, please.
I'm doing it now. I'm so sorry, my lady. It's my fault, Dr. Finnis. 409-574_55. Just one of the quotations that you've provided the inquiry with. Quote 47 there from a CVF member. I feel healthcare is no longer safe now that masking has been removed. I find every visit stressful. I spend a week before and after feeling very anxious and worried. I can't cancel appointments. I need my treatments. I still need facial surgery for my skin cancer. But I've delayed having a minor surgery to have my port removed. It seemed safer in 2020 because everyone was masked, there were more virtual appointments available, and the hospitals were much quieter. I just wanted to bring to life something that one of your members had said to support the findings of the CVF survey. I think, though, you were going on to say, Doctor, and it's my fault I interrupted you, that there was several things in the current guidance that you wanted to tell us about.
Yes, so that's the, as I say, the gov.uk, and it's replicated within the NHS guidance as well. It says 4 key things. Firstly, it advises us not to be around people who have COVID-19, nor people who have respiratory infections. It tells us to try and do, to get the people visiting us to do a lateral flow test before they visit us. It tells us to ask people who visit us to consider wearing a mask or face covering, although that does actually say face mask or face covering, or us to use a face mask or face covering. And it also tells us to consider ventilation. It also tells us not to go into busy, crowded areas and to reduce attending those. Now, I just want to really kind of talk about the juxtaposition of that guidance with healthcare. How can people who are advised to follow that guidance now safely access healthcare today?
Yeah. Do you get any information as to who is or isn't COVID positive?
No, there is now no testing. There's no formal testing, so you can be put next to somebody who is COVID positive. Of course, clinically vulnerable people are high users of healthcare. That's our greatest problem. And when we walk into A&E, we're in a busy, crowded environment, multiple people coughing. The last time I went into A&E, I cannot follow the guidance.
Is that in part why CVF advocates in the statement as they do for the return of face masks in all high-risk healthcare settings for both patients and staff?
Yes.
Now, can I ask you, Dr. Finnis, what is meant by the phrase high-risk healthcare settings?
So I mean, I suppose, ideally we would say that, almost all healthcare is high risk given the people who attend healthcare. However, high risk could be, for example, and perhaps other people need to determine this rather than me, but I might suggest it would be A&E, general medical wards, haematology wards, cancer wards, but also places where those people go. So if I may, I did hear Professor Hopkins last week or the week before tell us that she still would advise some of those precautions in those high-risk wards. But as someone who is high risk, I have to go to blood tests, A&E, clinic appointments. I don't just stay in those areas. I walk the whole hospital.
Yeah. The statement that you've provided actually goes on to outline some interim measures that CVF would advocate for. And could we look at and screen at INQ 409-574_58, please. And it's your paragraph 145, Dr. Finnis. And you set out there some of the measures that the CV people would contend for, allowing people to wear their own, either FFP3 or FFP2, enabling people at higher risk to easily request staff to wear masks before their appointments. Can I ask, has there been any examples among CVF members where they've asked a staff member to wear a mask and that the staff member has refused?
Yes, many, every day. It's a problem we face every day, and some of CVF's activities are around advocating for people.
Allowing high-risk patients to wait in a different settings, maybe in their car or in another room until they're called in for their appointment. Mm-hmm. Monitoring carbon dioxide, improving the waiting rooms, and there you make reference to mechanical or natural ventilation or added HEPA filtration. Mm-hmm. Improving the consultation rooms, staff working in a setting with clinically vulnerable patients to wear FFP2 or if symptomatic or not symptomatic, and at the request of a patient they do a lateral flow test, offering people the first early appointment in the day, and offering a digital option to those who prefer it and for whom it's acceptable on a clinical basis. Now, a number of practical measures set out there. Mm-hmm. Are any of those happening routinely as far as CVF members are concerned?
No, I mean generally not. So nothing happens automatically at all, despite that guidance in the NHS and in the government gov.uk. So, I mean, practically all really of people that within clinically vulnerable families have significant underlying conditions. So we frequent healthcare, myself included, often. So we have tested all these things. We do wear FFP3 and FFP2, and it's very variable. But as I said, many people do get a very bad reception. Not personally, actually, but certainly many people have really suffered what you would term, or we have termed, CVF mask abuse. We have no way at the moment to ask staff to wear masks. And in fact, even if we do, we often find that it's not then done. So, for example, we've had clinically vulnerable people who have gone in for an operation who would normally wear a mask, who are worried that after they're anaesthetised, for example, in the recovery room, they're worried that they will be exposed to COVID, and they've asked whether they can people wear masks. Either there's a battle at that point, to be honest, because it's not guidance, they follow IPC, or somebody says they can, and then when they arrive, it's not anyway. So it's kind of 2 points where that fails. Allowing high-risk people to wait in a different setting. So there are examples of that, particularly in things like dentists tend to be quite good at that. But it's in hospital, it's very difficult to do. It doesn't appear to be able to be done. There's also another thing that could possibly happen, which is high-risk patients wait in a different area, so like a mask area. The only time I've ever seen that was probably about a year and a half ago, where there was actually a mask waiting room for COVID-19 vaccination. So I have seen that once. That's another consideration. There's no CO2 readings available. Some of us carry our own CO2 meters, but obviously we can just measure it. There's nothing we can do. Just to say that I was in a big London hospital pharmacy a while ago, and it was pretty packed, and I had to get this medication, and the CO2 reading was well over 3,000. And the kind of safe level is between 800 and 1,000. So that shows you the problems. Obviously, the waiting rooms can be, it's a very old estate in the NHS. So there's really no kind of modern mechanical ventilation. Often the windows are kind of painted shut. There's certainly very few and far between HEPA filtration machines, although we have seen them in some hospitals, few. I don't think very few of us, any of us, in fact, have really managed to get a staff successfully to wear an FFP2 mask, ditto an LFT. They will sometimes offer us a first or early appointment in the day, but again, it's on us, you see, it's on us, this personal responsibility that's so hard to negotiate in that kind of relationship. with the healthcare system.
Understood.
Yeah.
I want to pause you there because you've given a number of things I'd like to pick up on. And I wonder, my lady, if that might be a convenient moment for lunch and I can bring back some of those answers in the afternoon session.
You're all right to come back after lunch. I'm sure you were warned, Dr. Finnis. Thank you very much indeed. I know that the team and I have other commitments at lunchtime, so I'll return at 2 o'clock.
Thank you, my lady.